Hello, everyone, and welcome to our Greeley Healthcare podcast. We're continuing our series with Tales from the Field. My name is Sally Pelletier, and I'm the Chief Credentialing Officer and the Advisory Consultant for the Greeley Company. We are continuing, as I said, our discussions with medical staff services professionals and how our folks in the field, both in and out of the work environment, have been impacted by COVID-19. I'm here with Frances Poncione, who is a senior consultant at Greeley in the credentialing practice. Frances is going to serve as a co-moderator for our podcast today. Welcome, Frances.
Thank you, Sally. I'm glad to be here today.
Frances and I are joined by two site directors for the Greeley Company, Monica Monreal and Glenda Ziesmer. Let me explain quickly what I mean by site directors. Monica and Glenda oversee medical staff services departments that are outsourced to the Greeley Company. Monica serves in this role for the Christus Santa Rosa system in San Antonio, Texas, and Glenda serves in this role for Mission Hospital in Mission Viejo, California. Both Monica and Glenda are going to share their experiences from the field in dealing with COVID-19. I welcome you both and thank you for your time today.
Thank you for having
us. Before we jump into hearing from Glenda and Monica about the variety of issues that they were involved with during COVID-19, I'd like to take a moment to frame our discussion and refer our listeners to our Greeley COVID Resource Center. We have blogs and other podcasts that can be found at greeley.com. That's Greeley.com. Glenda and Monica, in their time lately, over the past several weeks, have certainly been involved in having to manage both disaster privileging and temporary privileges. However, we have addressed those items previously both in blogs and podcasts, so our focus today will not be on those particular issues, but other challenges, stories, services, experiences that came about as a result of COVID-19 that Glenda and Monica have been involved in. And with that, we're going to start talking about, I know both of you, Monica and Glenda, you've shared with me just how much you've recognized, and others have recognized, if you will, the value of the Medical Staff Services Department as a resource to support your organized medical staffs during this time. I know that all of us that are on this call are passionate about what we do, and we are always touting the importance of what we do as a profession. But if you would both share with us some of those experiences that kind of, if you will, took you over and above your day-to-day activities. Glenda, maybe we could start with you. What types of services or additional resources did you find yourself having to deal with during COVID?
Thank you for asking me to be part of this conversation. Probably the most overall reaching area that we were asked to participate in or found the need to be participating in is to be the voice between the command center and activities going on in the hospital to the physicians. Many of them are not in the hospital every day to get that information, so we had to really build some really robust, timely communication systems to get all of the information, the activities going on in the hospital addressing the COVID to all of the participants and the physicians coming into the facility. In addition to that, we found ourselves also having to help participate in helping the physicians get fit tested for their PPE, keeping them stocked with their PPE equipment, and also sort of running a little bit of interference between some of the concerns that were being rumored versus some actualities, and making sure that the physicians got clear information as to what was going on.
Well, let me ask you a couple of questions about that then. So going back to really the command center and all of the communication. Can you share some examples of the types of communication and what some of the ongoing communications were that you were involved in?
We have the command center at our organization was set up quite early. We added very quickly to our daily safety huddles a COVID update, and would then on a daily basis, sometimes twice a day at the beginning of the pandemic, sending out communications to all of the physicians as to new practices, new restrictions, new processes that were being implemented to accommodate our patients and to keep our caregivers, including themselves, safe. And in addition to that, also making sure that the targeted audiences for the messages were specifically targeted, that the information was distributed to each specialist based off of their needs versus what the needs of the whole as a hospital. We set up learning boards throughout the facility, including in the different lounge areas, where we would post this information as well as distribute it. We would distribute it not only to their hospital email addresses, we would also send to their personal email addresses so that we could ensure that the information was being fully communicated.
Perfect. And I'm sure, Monica, I'd love for you to weigh in on that as well. You probably had something similar. But before we transition to you, Monica, I will ask Glenda to comment, and Monica, you can include it in your comments as well. Did you find that your emails and cell numbers, or were they accurate? I guess that's the best way to say it. Any challenges with actually getting people to respond? Did you have the right emails? Did you have the right phone numbers? Those kinds of things?
We didn't have issues with phone numbers and emails. I think the opportunity that we are going to continue to work on improving is our groupings. Oftentimes the hospital refers to, a particular group of physicians. They'll say, they'll call one group of physician hospitalist or intensivist, or they want to take information to go to a particular group of physicians. The trauma physicians, and to make sure you got all of the individuals that were participating in those roles included in the emails, even those that provide those services on a part-time basis. I think that was the opportunity that we identified that we can do a little bit better on in working with our physicians and getting them properly identified as to the locations they're working, the positions that they're filling when they're coming to the hospital, in addition to what they may be doing as a private physician.
Okay, thank you, Glenda. And Monica, how about you? What was your experience like with the command center and also with sending, being that key resource for sending out communications and so forth?
So, Christus, much like Glenda's facilities, we're doing pretty much the same thing, was being a resource to our command center around the clock. We were definitely, if the medical staff director in my role was the point of contact for the department, and we had to be readily available as communication needed to be distributed. Your question was, what tools or how did we get the information out? So we have some digital boards in our physician lounges, and the command center has a system that they use. It's an Everbridge system. We were fortunate to be able to partner with our IT vice president, really is who took the lead. We gave him and extracted email addresses and cell phone numbers, and they were able to put that information into the system and group them, as Glenda had mentioned. So we were fortunate to have that added support to help group the individuals, or at least by specialties. We were, oddly enough, you would have thought that the scheduled meetings would have maybe decreased. And what we found was that the meetings were actually being held either weekly or every other week at an MEC level. Our medical executive committees were asking to meet more often so that our leaders, both administrators and physician leaders, were able to effectively be up to date and effectively communicate what was the current status of its organization or of its facility, because we have 4 facilities under one hospital license. And so that was really important. We use tools like Zoom and Skype or just simply teleconference to set up these meetings so that everybody could call in. We were meeting as early as 7 in the morning or as late as 6 p.m. So it was interesting, and I echo all of Glenda's mention about the team huddles. What we did find was that the hospitals were desolate. There wasn't as much activity in the hospitals, with the exception of course, the medicine part, but the emergency medicine departments were almost vacant. So that was interesting.
Yeah.
Surgeons obviously were not operating because a lot of the surgeries are elective cases, so they weren't operating. But still, everybody out in the community within the whoever was on staff wanted to know what's going on, what phases are we in. So that was important.
Absolutely. Absolutely. Well, it sounds like both of you have established the fact that medical staff services is very key at the command center, as well as those issuing those communications and so forth. Monica, I guess one just additional question for you. Do you anticipate that some of that, the virtualness, I don't even know if that's a word, but maybe I just made it up, virtualness of your meetings will continue going forward, or do you think things will go back to status quo?
I really think that they appreciate the convenience of virtual committees. We did find that they prefer, a certain application, so they prefer Zoom over Skype. So it was interesting to see how they were able to adjust as our departments were adjusting, even just to keep our production going and staying in tune with all the other elements of having to be in a virtual setting. They too adjusted. So I think we will continue on in this fashion. It was very helpful.
Glenda, a couple of questions for you, because I know that you had mentioned earlier, and this seemed like a kind of an unusual fit perhaps for medical staff services, at least for me, but you had mentioned that you'd been involved in arranging fit testing for the N95s for caregivers, and you had worked with nursing on developing some standardized procedures for screening. Can you tell us a little bit about what your role was in each of those situations? So did you do some specific tasks related to that, or was it more coordination?
For the arranging for the N95 fit testing, it was probably more of a clerical role. That was an issue that we had already, as a medical staff, been having ongoing discussions on with our occupational health department on considering whether or not we wanted to start to add to our onboarding and annual health requirements the N95 fit testing. As an organization, it was a request they asked the medical staff to start considering. We had been already in discussions with our occupational health department regarding resources being available and scheduling for how we would go about getting our physicians tested on an annual basis if the medical staff put this requirement into place. Then with COVID coming, we were in the middle of those discussions, it kept me in that loop because we realized we needed to get this done to address the issue. We would bring back up the ongoing need for this later after the pandemic, but to get those physicians that needed to be fit tested done immediately. The role I played more here in the medical staff office was working on a schedule by specialty so that we could get the most critical doctors that were needing this, such as your ICU doctors, your pulmonologist, your ICU, ER, anesthesiologist were sort of my first group of doctors that we set up for, special training for. And it was, my role more was the scheduling piece of it. The hospital provided the actual trainers. And for me, it was more just getting the physicians scheduled, giving them a time, and getting them there present for that. With standardized procedures, that involved the medical staff office from the standpoint that we oversee and support the interdisciplinary practice committee that is required here in the state of California for overseeing what all extenders of the medical staff do. And we are responsible additionally for the annual review and approval of all standardized procedures. So that was the role that our office played in working with the hospital and the nursing department on getting standardized procedures in place for the nurses for the COVID testing.
Okay, well, thank you very much for that. Very interesting. I'm going to shift back to Monica just for a moment. Monica, you, as well as Glenda, but I'm specifically thinking of your military environment down there in San Antonio. You had mentioned that there was some interesting information to share with our listeners related to the shuffling of the patient population and specifically in regards to military personnel and so forth. So would you talk to us about that experience and how it impacted you and what you had to do?
Absolutely. So we in San Antonio have a pretty significant military presence, and but we found not just the military, but even our other, like I mentioned earlier, we have 4 hospitals under one license. And what we found was that our adult population were trying to accommodate or ask if they could shuffle some of their adult patients to our children's hospital. And the other request we had was our military physicians, or the military base, Brooke Army Medical Center, was shutting down, or did shut down, their pediatric subspecialties to make room for the adult COVID patients that they anticipated the volume of that patient population to increase. And so, you know, the urgency, so you had to take into consideration the urgency of both requests. One is, you know, can you accommodate? 2 is, you know, with all the state waivers that were going on with regard to licensure. So with all of that being said, the request for having the adult patients going to the children's hospital was not one we could accommodate because the competencies for our clinical staff are not there. Just bed capacity with regard to tools and supplies. So that was a no. And then the Brooke Army Medical Center request, we had to, we had to be aware that this was going to take place long term, and it was not going to be kind of a temporary 60, 90, 120 day situation. And so what we decided was we would first put in place the agreements, the legal agreements. There's a document that needed to be put into place so that we could identify exactly what patient populations would be treated, and would they just take care of their military dependents, or are we, you know, considering having the military physicians treat our civilian population? So all of those things had to really be thought about critically thought about and not just react to the, well, it's a COVID situation, let's just kind of process them as disaster privileges and move forward. So, I had mentioned, I think in our discussion prior to this podcast, that medical staff services really is the calm in the storm. We have a lot of panic, from leaders, from our physicians, and we really needed to be that level head of digesting the information and really giving it good thought before we reacted. So those were some of the things I saw.
Wow, excellent. An excellent point. I mean, I'm sure just thinking through, as you said, critically thinking through continuing to provide the best quality care that you could. And so taking each circumstance under individual consideration, if you will, to make the right decision. And it sounds like for you, one was a yes, we'll go forward with some reasonable details worked out, and the other one was you couldn't, as you said, you couldn't accommodate and you weren't going to move forward. So thank you for sharing that. I think that it's time for me to turn this over to my co-moderator, Frances Poncione. And Frances, I know you're going to take us through some additional areas, segments of the podcast that kind of move beyond the valued resource piece into a couple of other buckets. Would you please take us through those sections?
Thank you, Sally. This is just an amazing conversation that we're having with Monica and Glenda, and I really appreciate the opportunity to be a part of it. Some of what I want to ask is to dig a little bit deeper into some of the comments that both Glenda and Monica have already made. Specifically, as you talk about the role that you played in the communication between the hospital or hospitals and your medical staff, as well as the personnel within the organization, I'd like to ask a little bit more about some of the orientation or education that you might have been providing as part of that communication. So I know that many organizations had to put up some very specific guidelines and requirements for visitors, for physicians, for anyone entering into the hospital setting. So I'm curious if both of you could share with me, with our listeners, what some of those requirements were at your own facilities, and then what role did you play in how you communicated to the medical staff what those new requirements or guidelines were going to be put into place and enforced that they would then also have to adhere to. So Monica, could I start with you? Were you involved, or what involvement did you have in that sort of communication and orientation to your medical staff on these new guidelines as a result of COVID-19?
Well, that's interesting you say that, because when the governor deemed this to be a pandemic, we were sitting in a medical executive committee at one of the facilities, and the CEO of that hospital said, we are increasing our security. We are locking down all access doors. We're only going to have one entry in and one entry out. And it just kind of startled me, because it took me by surprise. But after that, each facility followed the same process. And what we found was that we had one particular facility that was very lax in the comings and goings of their medical staff. So all the locked doors, they didn't have the proper identification badge to unlock these doors, secure sites. And so we had to send out, again, we used our texting method that we had established through our Everbridge Command Center. And then each facility, we did not participate in having signage put up, but each facility took it upon themselves to put signage at each door, notifying the patients and visitors that the doors were going to be locked and that they had only one way in, which was through the emergency department. And at the emergency department, they would do whatever screening. At the time, we didn't know that we were going to be doing temperatures and that sort of thing. The first initial phase was that only one guest could come in with a patient. And then that soon turned into no guests. So you can imagine the patients and their families were a little frustrated. And then soon after that, they immediately went into testing. So we didn't really participate with giving that notice or posting notices, other than disseminating the information via email or by text. And then where we were affected was we actually had to begin working diligently to identify the physicians at that one particular facility, to issue badges, have them visit our business office, and get that process done. And it took us about a week and a half to 2 weeks to get it all squared away. But that was what we saw.
Okay, now that's great and interesting how the importance of the badge suddenly is now at the forefront of this. So, for physicians that might not have been as compliant with that requirement, now suddenly it was very important for them to be compliant with the requirement.
Exactly.
So, thank you for that information, Glenda. I'd like to hear from you if you had any of same similar situations or similar participation, and how you were, the role you played in orienting your medical staff on any of these guidelines or requirements that were now required of them to adhere to in order to be in the hospital setting.
Thank you. Our situation was very, very similar to what Monica has already described, so I won't repeat. We were primarily the voice of communication to make sure all physicians knew which entrances in the hospital they were allowed to now enter. And we did have a similar issue with some of the entrances not accepting the physician's badges for entering for multiple reasons. Most commonly, if you don't use your badge at a particular card reader for a period of time, it will automatically disable as a security safety role. So we did have to partner with our security department and get access back granted to these different accesses that so physicians could easily enter the building.
Okay, all right, thank you. So I know in previous conversations and also having an opportunity to be at your hospital there in California when this early in the stages of COVID-19 coming, I understand that there were some requirements that from a screening perspective of the physicians themselves. So not necessarily a screening of coming into the hospital, but if a physician had traveled to any country outside of the U.S., or if they had exhibited any signs of illness, there were certain quarantine requirements being placed on them as a precaution. Has that continued? How have you communicated that? Is that something that, Monica, you've also had to do? I'd be curious to hear what that sort of screening process looked like at your organization.
Yes, we early on did put out a feeler to our medical staff community to inquire as to where they had traveled, and most importantly, what stops they made in between their destination and arriving back at, and how much time had transpired between when they had gone on their trip and the current situation. The physicians were very compliant in contacting us and giving us that information. We would then share it with not only my medical staff executive COVID team that we had put together, similar to what Monica had described earlier at her facility, but also with the command center. And the physicians were given the opportunity then to come in to make sure that they were screened and safe, and that they had been properly taken off of duty if they had been exposed and off for the required period of time. That is something that will be continuing to monitor. Physicians are still contacting me and giving me their plans for where they are going to be going and making sure it's okay that they come back to the facility.
Okay, thank you. That's very interesting, just the dynamics of that. So I appreciate you sharing that with us. Monica, do you have anything to add to that? Any similar experiences specifically to that sort of screening process?
You know, this, much like Glenda mentioned, I mean, pretty much it was it was left up to the practitioner. We put the information out, offering to help redirect or provide screening for those that wanted, but because it was kind of a self-disclosure, there wasn't any required process or, you know, implementation that we had put in place. They were aware of a few physicians that had traveled. If you recall, I think this all kind of started during spring break.
Oh, yes.
So when they were returning, there were some physicians that people knew that they had traveled during that week. And so upon their return, they were the ones that were being called by the presidents or the CEO of the facilities on a personal level, just to ask them, you know, hey, we've got this available. Would you like to get tested? How comfortable are you? That kind of thing. So those were very one-on-one conversations. I will mention that there were some physicians that did turn out to have been exposed and but didn't know. So the early signs, even if they did have it, I think there was 2. They weren't aware of it until later. So I do know of 2 physicians that did have the virus here in San Antonio.
Okay. Well, thank you both for sharing your experiences in that area. What I'd like to do now is really move on to another category that I am certain you both will have some very interesting experiences to share with us. We've talked a lot about the physicians, the medical staff, how you have been that resource to your administration. But let's talk about what happens in the medical staff department. I can only imagine that there were a few challenges as states were mandating that you stay home. If you're essential personnel, you're able to go to work. We are essential personnel, absolutely. However, the work that we do, we can really consider other ways to still deliver what needs to be done. So I'd love to hear from you what some of those challenges might have been as you transition to working remote. Did you fully, move your entire staff? Did you keep some on site? Give me some of your experiences as you really had to address your own staff in the medical staff department and continue the work as usual, but in a very different way.
And Francis,
so Glenda, if you could.
Francis, this
sorry,
is Sally.
Yes, Sally.
Can I interject there? Because I want to recognize as well that not only were Glenda and Monica having to deal with moving their staff remotely, but we really were moving remotely on them at the same time.
Yes.
So they had
true.
an added consideration there in terms of remote offices. That's unique, perhaps certainly to the outsourced Greeley sites, but I just thought I would interject that as another consideration as they give their responses, because I know it wasn't easy.
No, definitely. Thank you for mentioning that, Sally. So essentially, not just dealing with how do I take care of my medical staff, but also from a company perspective, there was a lot of directives going on as well that had to be adhered to and taken into consideration and managed appropriately. So lots of challenges, lots of hurdles to get over. So would really, again, just love to hear some of your experiences with that, the good, the bad. Just share your experiences with us. So Glenda, I'll open it up to you first, if you don't mind starting and sharing with us.
The biggest challenge that we have identified at our site is the ability for accessing all the information that we need. Staff were allowed to go home immediately. when the governor put out the order for their safety. It was a very big satisfier for the staff to feel that they're being safe where they're working. But we continue to have to work through some of the challenges of not being able to access all the information. It did necessitate the need that we do keep somebody boots on the ground in the departments for responding to those things that come into the department on an ongoing basis, and also then being the conduit between my remote workers and the office to be able to disseminate information to them that they needed in order to continue to do their jobs without that full access.
Okay, thank you, Glenda. I really appreciate that information. I can certainly appreciate the need to have someone on site to manage the day-to-day. Was that something that you were having to take on? Were you that individual that was primarily in the office setting, or was it something that you shared with another staff member?
I'm fortunate to have a staff member that can help me out in that, and I have assured both the medical staff and the hospital that one of the two of us would be here at all times. And I certainly made sure that they were comfortable with that arrangement before we moved forward. But it has required probably more of my need to be present on site than I probably originally recognized when this first came down.
Okay. All right, great. Thank you very much. Monica, can you share with me and our listeners any of the challenges that you and your staff might have faced with transitioning to being on site in the hospitals to a more remote work?
Sure, no problem. So Christus, fortunate, unfortunate, I'm not sure which, but here in Texas, we had Hurricane Harvey in August of 2017, and our Credence site, the Greeley Credence site, has been supporting Christus now for about 7 years. So we had the opportunity to experience the need. Again, disasters come in so many different forms. And so in this case, it was a hurricane. And at that time, we had the opportunity to kind of stretch our legs with learning how to be remote and exercising all the do's and don'ts of how to do remote work. And so since 2017, my staff, part of their, when they onboard with me, is to get VPN access. Sometimes, when we get called and we need to log into the computer, those were the easy things. But in this situation, when COVID hit, our due diligence was how fast can we move staff out of the hospitals, because we are in the hospitals. So we brought them into our business office, and our business office, there's an office for each person. So there was social distancing and then some. So we brought them into our business office first. That was our phase one. And then quickly we realized that our staff had some anxiety, a lot of concerns, as you can imagine. And so Christus was gracious enough to say, if they want to take some of these monitors home, whatever equipment they need to do their job, just let them borrow it. Our backup, of course, was Greeley was ready to send and deploy whatever equipment we needed. So that was nice. We did have some, I'm going to call them a hot box, and that's not the right term, but these are hotspot boxes so that you can have Wi-Fi, kind of a portable box, if you will. Because what we found was that the bandwidth, or not everybody's homes had the right bandwidth to be able to do the work. So Greeley was able to provide those to us fairly quickly, and I was able to issue those. Staff would come by and pick up whatever they needed. But all of this for us happened within 2 days. Greeley's boxes came in over a course of maybe 3 days or so, but they would pick them up as needed. So, you know, we were able to email in, email out, so that we know where they're at. Our applications are in a electronic fashion, and so we're able to process or sign on remotely. So that's a benefit. So those were our experiences. We continue even through today to work remotely. We did have 2 people that stayed on site, that being myself and one other individual that said, I've got college students at home, 3 of them, 3 daughters that are at college. Everybody's using the computers. Her husband supports another healthcare system here in town. So she says, I'm comfortable staying. So luckily I have a companion at the office that, like Glenda, that we're able to be boots on the ground and ready to support our administrators, you know, as needed. So that's been our learning through this process.
Great. Thank you very much for sharing that. So with your staff working remotely, for the most part, have either one of you developed some ways? What are some of the ways you've developed to stay in contact with them? Are you typically when you're in an office setting, you can have a daily, weekly huddle, you can have a department meeting. Have you been able to have those same types of meetings, those same types of communication with your team? And how have you been doing that since they are working remotely?
This is Glenda. That has worked out very successfully for us. We have daily calls every morning as a group, conferences, and we review what each other is doing for the day, what their goals are for the day to get accomplished. We discuss any challenges, share any concerns, frustrations, anything we need to deal with. And actually, it has probably increased our communication because it forces us to meet every day, and we don't allow our schedules to get too busy to take out the time to have that conversation between each other.
Nice. It's a good way to still stay connected and definitely keep everybody in the loop of what's going on in the department. Monica, what about you? Have you had to do anything similar to that?
We, yes, actually, we're not meeting. We probably have weekly meetings, but they are staying in touch. So we have instant message through our Skype business application. You're able to ping each other and ask questions. You can tell if people are actively on the computer. You can even call them on Skype. And so you can't visually see them, but you can call them on Skype. And so I prefer just to hear a voice and let them know that we're still here for them. I check on them probably weekly. We do team huddles weekly. But it's been nice. I think they feel better to be able to work from home and be with their children that are being homeschooled, because I think everybody's trying to multitask, not just work, but their daily lives, because everybody was asked to quarantine for as long as we have. So it's been interesting, but I will say that we have stayed productive throughout this process. And best of all, we are all still employed. So I have to tip my hat to my employer. So yeah, we're working through it. It's worked out well. I look forward to the day that we can all come back in the office and work together again. So
yeah, definitely.
Well, Frances, that might be a perfect segue for us to talk about the road to recovery post-pandemic.
Yeah.
You think? Yeah.
I think so. That was a
yeah.
good lead into it.
It was perfect. So I know that both of you, Monica and Glenda, and Frances too, I think, have shared with me that any prior dress rehearsals, so to speak, for disaster planning have not did not prepare us for something like COVID-19. I suspect this is something we'll be telling our children, grandchildren, we could write books, right? We could always write books in medical staff services departments, but this would be a pretty big chapter for sure. I know that you both have shared that you're starting post-pandemic planning, and Glenda's already mentioned a couple of things that she wants to be more proactive about going forward. But we'll start with Glenda. Can you share with us kind of where you're at in the recovery? We'll see how California kind of compares with Texas, and what your key takeaways are.
For the medical staff, the main thing that we've been working on is setting up the criteria and for the types of elective cases that we are going to allow to come back into the hospital in the phase process in which we're doing that based off of the service. We've also worked on the testing requirements and setting up testing sites for the elective patients to get their testing done once cases are being scheduled or treatments, so that they can have that validated before the scheduled time.
Is there a date for that, for those elective surgeries to start back up yet?
We actually started back up on May 1.
Okay.
So that work has already been done. What we are continuing to do is to work on continuing to open up more as we are able to, and as we can address the safety issues and get more equipment and processes in place. It is allowing us to continue to open up more and more of those services. Those are continuing to happen, but the soft start started May 1 and is continuing throughout this month at different levels based off of the resources that are available. For the department, we are still working primarily remote. Just myself and one other are here still on boots on the ground. We will be looking at how that transition back into the workplace will look for them based off of not only governor's orders, but based off of the safety concerns of the staff, to ensure that they're all feeling very comfortable before they return back to the workplace. I think it's also an opportunity for us to really evaluate workflows that got highlighted in this process, and how we might be able to improve on those processes, in addition to improve on our abilities to look at more alternative ways of doing business, to be more not only proactive, but to be more efficient, and also to be a little bit better prepared for any future surprise experiences that we may get faced with.
Sure. Well, thank you. I know, as we go forward, I mean, none of us have a crystal ball, but I suspect that there'll be quite a bit that will be changed, and hopefully for the better, in terms of, I think it was your word, maybe it was Monica's, but be more nimble going forward. That's a good thing. And we've always needed to strive for more or greater efficiencies in the medical staff services department. So maybe this pushed us a little farther along than we might have been normally at this point in time anyway. Monica, how about you? What's going on in Texas in terms of starting back up, and what will you do to be more proactive, perhaps for your next disaster?
So Texas, like California, has already started its surgical cases. I don't believe that they're doing elective. They have to be urgent, emergent cases. I don't think that they will start doing elective cases until maybe another week or so, but they are screening all their patients. They're screening physicians, and they're screening associates that are going into the ORs. We've had, like I said, we've had multiple meetings with the MACs, and every facility, interestingly enough, has opted to do something just a little different. But that being said, I think, patient care and safety is at everybody's forefront, so that's good. As far as our office and our team returning to work, our goal is to try to stagger our team to come back into the workplace with a goal of being back on site for everybody by June 1. That would be nice. But, a lot of people still have anxiety about, is it safe? Are we, is it time to come back? But as far as processes and how we can improve, we are actually in a transition between credentialing databases. And so this has been definitely a learning curve for us on how we can take the most benefit out of the new credentialing database with all of its, ePriv, VCOM, all of those tools that are made available to us in this new credentialing database. So that's really been our learning curve and opportunity to improve upon once we all come back together. As far as being technology, up to date on technology, I think we all did a really nice job of making sure staff had the tools they needed, bandwidth, all of those things. And so I feel confident that should we have to send or deploy people back home, we have the tools and we have a plan in place so that if it happens again. And I really don't think that we should wait. My suggestion would always be not to wait for, an urgency to send people home. I think it's good practice for us to work from home every now and again so that you can develop those processes and make sure that find out who is good at working from home and who isn't, because not all of us are cut out to work from home. So those are important things to learn and to identify. And I will be the first to say I prefer to be in an office setting rather than to be at home. So
yeah, there's definitely a different characteristics for those of us, whether you're an introvert or an extrovert or whatever, do you like the social aspect or not? Yeah, I love working from home, but I know it's not for everyone for sure. So thank you both. We're going to move into wrapping this up, and I just want to recognize both Monica and Glenda. I know that they have been really on the front lines for us for Greeley. They've been they and their staff have been doing a great job, but Monica and Glenda in particular have really been bearing a great deal of the load because they have been those boots on the ground. So I want to thank you both personally for your time today, as well as for the time you've put in to support your facilities during COVID. I will start with perhaps Monica, just any closing thoughts from your perspective, and then Glenda, I'd love to hear some closing thoughts from you as well as from Francis.
Well, I just want to say thank you for having me. This is my first podcast, and my son thought that I was like a rock star or something when I told him this. So thank you for having me. And to all the MSPs out there, I just, I think it's important that we all remember that we truly are that front line. I know we're not at the bedside, but we definitely have a hand in ensuring patient safety. So best of luck to everybody out there, and thank you again for having me.
Thank you, Monica. Glenda?
I also want to thank you for letting me participate. It's been a wonderful experience for me to go through this. I like learning experiences, so from that standpoint, I call it wonderful, just for a learning perspective. But it's certainly highlighted the essential need for the medical staff professionals and the role that we play in the hospital. Oftentimes, I think we feel like we're behind the computer or behind the wall and our work is not recognized and appreciated. But my experience over the last month has highlighted the fact that medical staff professionals do play an extremely essential role in ensuring that patients are kept safe safe in our diligence of trying to ensure that we bring in quality physicians that can meet those needs of our community.
Yeah, absolutely. Well, very well stated. Thank you. And Frances, I will let you take it away and finish up for us, please.
Thank you. Thank you. So I echo Sally's comments with regards to Monica and Glenda, and just appreciate all that you've been doing, all that you've been handling, your staff, yourselves, but just the exceptional job that you've been doing over these last few months. Today, what you've done is just amazing. I think that the time that you've taken to share with our listeners your experiences that are outside of the regulatory requirements, but just really what does it look like from a day-to-day operational standpoint. And I really appreciate and thank you both for sharing. And I'm certain that it will bring some value to our listeners, and they'll learn from what you've been able to share. So thank you so much. To our listeners, we appreciate the time that you've taken to listen to this podcast. We encourage you, as Sally has provided you, to visit our Greeley COVID resources page. There's a lot of really good information, lots of great blogs, podcasts, just some really valuable information that I'm sure you'll find helpful. So just want to remind you of that. You can be found on our website, greeley.com. and would encourage you to take some time to review that information.